All right, welcome everybody to Workshop 29. This is the power of data to impact patients, policy, and population. I am one of your co-chairs, Anna Fano. I'm a biostatistician at Seattle Children's Research Institute, and my co-chair here is Dr. Ed McCone, professor from the National Referral Center for Adult Cystic Fibrosis, School of Medicine at University College of Dublin. So this workshop will provide examples of ways in which large sources of data, which could be national registries or observational studies, can be leveraged to study population-level response to highly effective modulator therapies, mortality trends in countries without access to these, and then as well as new and emerging CF phenotypes of interest, especially rare outcomes. Large-scale data can be used to validate clinical trial findings and can help propel improvements in patient-level CF care through policy and advocacy. So our objectives for this workshop are to provide some examples of study designs and analysis techniques that you can use with large-scale observational and registry-based data sets. We're going to demonstrate how these studies can support and expand on clinical trial findings, and then finally demonstrate how large data sets can be used to promote advocacy and policy changes. I'm going to hand it over to my co-chair.
So thank you, Anna. So it's my pleasure to start the meeting by introducing our first speaker, Gianfranco Alejandro, who's a speaker coming from the Università degli Studi di Milano from Milan in Italy. And Gianfranco is going to present us on CF mortality trends in countries where people cannot access ETI therapy. So thank you.
Thank you for the introduction, and thanks to the organizer for inviting me to this session. In the next 15 minutes, I will show you how vital statistics can be used to evaluate mortality trends from cystic fibrosis. Specifically, I will show you how we used causes of death data to evaluate what we could expect in the coming years in terms of CF related mortalities in countries with limited access to elexacaftor, tezacaftor, ivacaftor therapy. I have no conflicts of interest to disclose related to this presentation. ETI therapy has radically changed the lives of many people with cystic fibrosis, but the therapy remains inaccessible for individuals living in countries with limited access to this treatment. And the main barrier is the lacking of reimbursement agreements in place in these countries. The consequences on CF-related mortalities remain unclear, primarily due to the lack of established registries in those countries. In this study, we used causes of death data to evaluate CF mortality trends in countries lacking reimbursement agreements. The data we used are that count by country, year, and age groups that we obtained from the World Health Organization mortality database, and the mid-year population is aggregated by the same factor that we obtained from the United Nations Population Division unit. Let's spend a few words about this data set for those not familiar with the WHO mortality database. It is based on death count, that when a death occurs in a country, local civil registries record this event, and along with causes of death data, all deaths are medically certified, and causes of death data are coded according to an international standard that is the International Classification of Disease. And then the underlying causes of death is selected. And this information then is submitted to the WHO every year from each country. The process of acquisition and transmission of this data is quite slow, because the data can take between 1 year to 18 months after closing the records to reach the WHO. An important limitation of this database that not all countries possess a vital statistics system. They do not have enough resources, and for several low-income countries and middle-income countries, we do not have causes of death data. The database contains the number of deaths that occurred each year in each country, disaggregated by underlying causes of death, sex, and age group. The access is free to this dataset. We selected from the database that with the ICD code for cystic fibrosis, that is E84, as underlying causes of death. We focused on the period between 2000 and 2021, and we selected countries with mortality data completeness above 80%. This means that 80% of the deaths occurred in the countries as an underlying causes of death. We selected countries who registered at least on average 5 deaths per year, and countries with available data for at least 50% of the study period. You see on the right side in this table an example of the data in the data set. We have the country, the year, the age, and deaths. We are working with aggregated data. Countries were classified based on the availability of reimbursement agreement according to the study published this June on pediatric pulmonology by Dr. Guo. We used as statistical indicator the mortality rates, the number of deaths with cystic fibrosis as underlying causes of death divided by the mid-year resident population in the country and multiplied by 1 million. We use this statistical indicator to take into account different population size across country and also in the different periods we analyzed. To estimate trend in CF-related mortality, we use a generalized estimating equation model with an autoregressive working correlation structure to predict this mortality trend. This technique allows for controlling for correlation on the same measurement in registering in each country for several years. Out of 156 countries in the WHO database, we use the ICD-10, which is the ICD-10 to code the causes of death. We excluded the majority of the country for the following reason: because they did not report CF as cause of death, because the suboptimal completeness, or because they registered a low number of deaths in the country. And we also had to exclude Egypt because we observed a large fluctuation in the data without any plausible explanation. We don't have any explanation for that. So we excluded the Egypt for this analysis. And at the end, we had 30 countries to analyze. You see on the left side of this slide, you see the ranking of the countries according to the number of deaths registered. We see that in the majority of deaths were observed in the United States, Brazil, and United Kingdom, in countries with agreement in place, while Mexico, Argentina, and Colombia registered the majority of that in countries with no agreements in place. On the right side, we see the ranking using the mortality rate. The highest mortality rate was observed in Ireland and United Kingdom, and the lowest one in Romania and South Africa. As you know, prevalence varies a bit across countries depending on the composition of the population in terms of ethnic group. As you can see this heat map on the left, the prevalence was higher in North Europe, in Western Europe, in North America, and lower in South American countries. On the right side, you see this scatter plot when we can observe this strong correlation between prevalence of CF and the mortality rate we estimated using this data. in the 20 countries with reimbursement agreement in place, we observed more than 23,000 deaths, and in the 10 countries without reimbursement agreement, we observed 5,700 deaths. The mortality rate was lower in countries considering the whole period. The mortality rate was lower in countries without reimbursement agreements. When we look at the age at deaths, we see that in countries with a reimbursement agreement in place, most of the deaths occurred in the third and fourth decade of life. While in countries with no agreement in place, the majority of deaths occurred before the age of 20 years, with 20% occurring in the first 5 years of life, and we have also almost 20% occurring at age over 75. We will talk about this data later. Let's see on the right side the trends by age group. We see that in the first and second decade of life, in both groups of countries, we observe a decreasing mortality rate, while at older age, we are registering more deaths over the period, an increasing number of deaths over the period. During the study period, in country with agreement in place, we estimated an annual reduction of mortality rate by 1.9% per year, and while in countries with no agreement in place, we observed a 3% increase in mortality rate. This increase can be likely explained by a rising in the implementation of neonatal screening in these countries, and probably also an increase in recognition of milder form of the disease. But you can see on the right side, when I show you the mortality rate ratio between these two groups of countries, that in around 2016, the two mortality rates converge. This means that the level of mortality became the same. When I first looked at the data, I questioned the reliability of this data, especially at the older age. As you see, we had like 20% of deaths registered in countries without reimbursement agreement over the age of 75. And I found a study by Dr. Elbert where he tried to compare the number of deaths registered in the causes of death database with the one registered in the CF registry of United States, and they found a good agreement in children, young adults, and middle-aged individuals, but lower agreement, less consistent data in the older population. So I performed this sensitivity analysis, including this group, the ages over the deaths at ages over 75. And as you can see, the estimate of the annual percentage change does not vary so much, and the main findings remain the same. We see a convergence of these two mortality trends in recent years. In this table, I compare the number of deaths registered in the WH mortality data set with the ones registered in the US CF registry, UK registry, and Italian registry. As you can see, there is there are more deaths in the WHO and in the Italian registry, while some undercounting in the for the UK, for data in the UK. But generally, there is an agreement, especially in the trends. In conclusion, we can say that mortality rates in countries without the reimbursement agreements are rising, and we can expect that in the coming year, the mortality rate will surpass those in countries with agreements in place. An important thing is also that individuals in this country are dying at younger ages compared to the ones living in countries with reimbursement agreement in place. We can also conclude that despite some inaccuracy in reporting causes of death at older age, this data source can be a valuable source of information, especially in countries without registry or with suboptimal convergence or recently established registries without historical data. It's only to thank my colleagues at the Ospedale Maggiore Policlinico and at the University of Milan. Thank you for listening, and I'm happy to answer.
So thank you, Gianfranco. Are there any questions from the audience? I might just start by asking a question. I mean, we know from the European registry recently that there are significant differences in outcomes across Europe that are determined by socioeconomic factors, and this was before ETI became available. And we suspect that those effects will be exaggerated by ETI not being made available in some of the Eastern European countries. I suppose, in what respects do you think that ETI access is really just another marker of socioeconomic differences between different countries, firstly? And second of all, do you think, you mentioned that the rates of CF deaths were lower in the countries that didn't have access. Is that they aren't ascertaining cases, that people who are dying of CF are not being recognized that they're dying of CF? A lot of these we call non-CF bronchiectasis. Is that a factor? Or do you think that do you think it's just simply that the rates of CF are lower in those countries?
Okay. I will start from the last question, okay? Of course, the problem is under recognition of cases, okay? Because we started our study by observing data from 2000, okay? And you see the mortality rate at that time was very low because neonatal screening were not in place in those countries, okay? So the increasing mortality trend is not because people are not treating or the treatment was worsening in the observation period, but because of under recognition of the disease in those countries. But now that countries are establishing registries and are recognizing the disease, if we don't do anything, probably the mortality rates in those countries will rise in the absence of ETI therapy. Of course, socioeconomic status is important. This is just a criterion to group the countries. I use the reimbursement agreement, but we can also use the socioeconomic status of the countries, and we will see, we will see also important difference. We know from the European Cystic Fibrosis Registry that there is important difference even in Europe.
Yeah, thank you for the great presentation. Question and then maybe a comment, but is the denominator for your mortality rate the total population in the country or the total number of people with CF in that country?
No, it's the total population in the country.
Okay,
it's the resident population.
I would maybe encourage you to consider using the denominator people with CF, and you might actually see a different picture with the lack of access, because not everyone in the country has CF, so they can't die of CF. So if you have a lot of people with a large country population, but a small CF population, their mortality rates will be low anyway. So it might just be interesting to look at where a rough estimate, even if they don't have an established registry, to see. You may see those countries that don't have ETI access actually have a much more stark picture.
Okay, I agree with this comment, but the problem is that we do not have the CF population in the period we analyzed. I do not have the denominator for all the years, because some registries, some South American registries were recently established, like if I remember well, Mexico in 2018. So I don't have data. I was forced to use the resident population as denominator because of the countries we analyzed. We don't have problem, of course, for European countries, but for South American countries, South Africa, I do not have data.
And we have time for one more question, maybe over to the left.
Yeah, thank you. And I'm not sure if I got the answer from your question before. So is lack of ETI access an independent confounder for case finding in the first place? So in other words, in countries that don't have ETI access in the first place, is that going to reduce the amount of full genome screening in those countries? And therefore, what you may be seeing is picking up more mild cases in countries with access in the first place, basically increasing the total population. So in other words, is this going to be a persistent case-finding bias because ETI access by definition may lead to more aggressive screening for people who could get ETI?
Of course, we have a bias here.
Right.
The bias is we do not collect all the real deaths occurring in those countries, okay? We have this bias. But with increasing the recognition of the disease, in the coming years, we will see a mortality rate in those countries similar to the one we observed in Europe or in North America.
I guess what I'm saying is that will the recognition of the disease increase at the same rate in countries with and without access, because access to the drug may change the aggressiveness in which people are able to screen for the disease in the first place?
Oh, I didn't get the point.
Yeah, no, I think the point is that the harder you look
Sorry
for
about
CF,
that.
the more likely you're going to find it.
Yeah.
And I suppose the challenge we face in terms of the denominator being the total number of people with CF in a country is that for some countries we don't know what that number could be. We know the number that have been diagnosed, but we don't know what the total number of people is with CF because they aren't all being screened. And I think that's part of it all, or they aren't looking hard enough for maybe rarer mutations. So I think that it's a moving target. That's all. I mean, I think what you've shown is some, crude trends over time, which are useful to see. I think nuanced analysis, when we start looking at how that varies with the prevalence of CF in the countries, would probably just give us a better sense of what the true differences are, and then possibly the true differences of ETI will have. Okay. Great. Well, thank you very much for that, Giancarlo.
Right, our next presenter will be Dr. Jordine Hergenroder.
Thank you to the moderators for the opportunity to come speak with you all and share our initial findings looking at the registry analysis of the real-world impact of ETI on nutritional and pulmonary outcomes in people with CF. This is the disclaimer slide, and I have no relationships to disclose related to this presentation. Randomized control trials, or RCTs, have demonstrated the efficacy of ETI in terms of improving lung function and nutritional outcomes. Now, while RCTs are the gold standard for research, they do come with strict inclusion and exclusion criteria and occur in a highly monitored environment, so may not be fully representative of the real-world experiences of people with CF on ETI. And so that's where real-world research can really come in and be a nice complement to RCTs, really getting at the effectiveness of a therapy. How, in practical terms in the real world, is this therapy helping? So that led us to our objective for our study, which was to utilize the CF Foundation's patient registry to assess the real-world impact of ETI on pulmonary and nutritional outcomes. We had two specific aims. The first being to estimate the impact among those with a stable prescription in 3 areas. So looking at lung function, specifically forced expiratory volume in 1 second, or FEV1, looking at body mass index, or BMI, as the marker of our nutritional outcomes, and lastly, looking at rates of IV antibiotic-treated pulmonary exacerbations. Our additional aim was to characterize the heterogeneity in response to therapy. So we included people with CF age 12 and above with at least 1 copy of F508del who had documentation of a stable prescription for ETI and who had registry data between 2018 and 2022. For FEV1, we chose to use the GLI global race neutral equations, and for both FEV1 and BMI, we looked at the mean in the year preceding ETI initiation and up to 3 years following ETI initiation. Additionally, we performed generalized estimating equations, or GEE, linear regression, which you heard a bit about in the prior presentation. For pulmonary exacerbation rates, we used a negative binomial model, and we're also able to adjust for secular trends in respiratory viruses during this time period. So initially, I show overall characteristics of the cohort, and I know there's a lot going on this slide. So just to orient you a little bit, in total, about 11,300 people met inclusion criteria for our FEV1 analysis. And we've stratified participants by their lung function. So those with severe obstructive lung disease with an FEV1 of less than 40% of predicted over on the left, followed by those with moderate disease, 40 to 69% of predicted, 70 to 89%, and then above 90. One point I'd like to highlight for you all is that actually 45% of our participants fell outside of the RCT inclusion criteria, which required that participants have an FEV1 between 40 and 90% of predicted. So we're able to look at a wider variety of people with CF with our real world research. The trends here really fall with what we would expect. For example, those with severe obstructive lung disease tend to be older, tend to have a lower BMI, have more pulmonary exacerbations in the preceding year, higher rates of Pseudomonas positivity, and higher rates of CF-related diabetes. So what were we seeing in terms of FEV1 trends? So the first figure I show you all is a violin plot, which is a nice way for us to visualize the raw data. Over on the left in gold, we're seeing the pre-ETI initiation data. So we've got our median, our interquartile range, and then not normally distributed spectrum of FEV1s. And then in the teal figures on the right, you're seeing 1 year, 2 years, and 3 years post-ETI initiation. And what you can see is that there is an increase in FEV1 among the overall cohort, and we're seeing a sustained improvement over time. But I would like to highlight for you all, you see this tail of sicker people, and you continue to see that tail with the post-ETI trends, although it's sharper. And this really speaks to the fact that while there's an overall improvement in lung function, not everyone responds the same way, and there's certainly a heterogeneity in how people respond. So then we looked at FEV1 over time with GEE modeling, and this is for the overall cohort. So to orient you all, over on the left, you're seeing this blue line, which represents the trends for FEV1 prior to ETI initiation. I highlight time 0 here, which is when ETI was started, and then the dashed blue line represents what we would expect the natural progression of FEV1 to be over time had they not started on ETI. And then in red, we highlight the actual trends in FEV1 over time once participants started ETI. So the first thing to call out is that for the overall cohort, there was an increase of FEV1 of about 10 percentage points. Though interestingly, the actual slope of the FEV1 over time is negative. So there is a slight decline over time of 0.15 in lung function, but in comparison to what we would expect for the natural progression, which was about negative 1.5, there's definitely less of a decline over time. So then we broke things down into those with lung function less than 40% of predicted. And you can see, again, an overall improvement of about 9 in FEV1. And in this group, there was actually a positive slope over time, so an increase in FEV1 of 0.3 per year in comparison to the expected trend of a decline of about 2 per year. Here, I show the data for those with FEV1 between 40 and 69% of predicted. And so we do see an initial robust improvement of about 12, but a slow decline, though, again, much less than among the predicted decline. We see similar trends for those with lung function between 70 and 89% of predicted. And then here is those who start out with really normal lung function, so greater than or equal to 90% of predicted. And what I want to highlight is that in spite of having normal lung function to begin with, they do improve by 7 percentage points in their FEV1. With our prior analysis, we showed that those with normal lung function were delayed in starting ETI, but I think this figure really highlights that there is still improvement to be gained even among those with normal lung function to starting ETI. So just to summarize what I've told you all so far, for the overall cohort, there was about a 10-point increase in FEV1 at the start of ETI. And even when we subdivided things by degrees of lung function severity, there was improvement among all of the groups. So what about our BMI trends? So again, I'm showing you all a violin plot. This one is a little bit more normally distributed, and you're seeing the same trends of an improvement in BMI post-ETI initiation that seems to be sustained over a 3-year period. But again, you can see there's quite a spectrum of BMIs, and so not everyone is responding the exact same way. So looking at BMI over time, I'd first like to note that this is absolute BMI. So our N is a little bit smaller than the FEV1 group because we're not looking at those with BMI percentiles, which we tend to use in the pediatric population. But we see an overall increase of absolute BMI of 1.1 and an increase in the slope over time among the entire cohort. We then stratified things by BMI, and so those in the underweight category with a BMI of less than 18.5, we found an even greater improvement in BMI initially of 1.6 and a continued uptrend over time in their BMI. We saw similar trends among those in the normal BMI category of 18.5 to 24.9, and among those in the overweight category. And then we saw a really interesting trend among those who are qualified as obese, meaning their BMI is greater than or equal to 30, where there is an initial improvement in BMI by 0.7, but the slope seems to essentially plateau over time in comparison to the expected natural progression of increasing over time. There may be many different variables or explanations at play here, and we were restricted in our analysis to really explore this, but I think it's quite an interesting trend that requires further exploration. So just to summarize for you all what we saw in terms of BMI trends, the overall cohort saw a absolute increase of 1.1 in BMI, and when we subdivided the groups into their nutritional status, we found that those with the lowest BMI initially saw actually the biggest improvement. So what about pulmonary exacerbations? So here we performed a negative binomial model, which allowed us to estimate incident rate ratios to look at the counts and person time among the unexposed time period without ETI to the exposed time period on ETI. And you see that in the unadjusted model, there's an incident rate ratio of 0.28, which means that there was a 72% reduction in pulmonary exacerbations. We then adjusted for varying rates of respiratory disease by including a covariate in the model that looked at higher rates of SARS-CoV-2 and influenza at different time periods. And even after making that adjustment, we still saw a reduction with an incident rate ratio of 0.65, so 35% reduced pulmonary exacerbation rates compared to the unexposed time period without ETI. So just to summarize what I've shared with you all so far, among the participants included in this study, 45% actually fell outside of the inclusion criteria for the RCTs. So it allowed us to see a wider variety of people with CF and what their responses are to ETI. We saw that FEV1 increased and was maintained over the 3-year period for all groups, and that BMI improved for all groups, but there was a plateau of that increase among those with a BMI of greater than or equal to 30. We also found that pulmonary exacerbations were less likely on ETI, even after adjusting for peak viral respiratory seasons. So with our real-world research study in conjunction with the RCTs, we found that ETI is both effective and efficacious. But there's certainly a heterogeneity in response, and not everyone is improving to the same degree. So we're in the midst of our analysis, and our next step is to look more granularly at those who didn't show an improvement in FEV1 and what are the characteristics of that group compared to those who show more of a robust response. And we're also planning to look at the correspondence between those who improve with their FEV1 and BMI. So do the people who improve with BMI also have the same robust improvement in lung function, or are there different patterns going on there? I'd like to thank the CF Foundation for the opportunity to use the patient registry and everyone who contributes to the registry, especially the people with CF and my co-investigators as well.
Great. Thank you so much, Georgine. Do we have any questions in the audience?
Yeah, I just have a quick question. How did you handle age? Because a lot of these things are age graded, and I found like the effective ETI varies by age.
Yeah, so firstly, we chose to include just people aged 12 and above, since that was the first group that was approved for ETI back in 2019 by the FDA. So we wanted to make sure we had plenty of data to look at. We actually included people who turned 12 up until June of 2021, when the FDA lowered the criteria to age 6. But subsequently, we excluded anyone who turned 12 after that. And that was really to avoid any bias of including those participants as soon as they got improved. And I'm not sure if that was the age question you were wondering about, or
The pattern of FEV over age, right? It's not just people with high.
Oh, yeah. So I think that's a really good point, because we know that all of our lung function does, decrease over time. And so that may be one of the things that could explain why there is that slightly negative slope, even among those on ETI. And I think it speaks to the fact that still, in comparison to what we would expect the natural progression to be without ETI, there's still definitely an improvement.
All right, great talk. 2 quick questions. One, have you used the non-ETI patients to see if your predictive trends for those who would not have been on it continue? So in other words, you have your control trend line, but you do have 10 to 20% of the population that either aren't getting it or are not taking it due to multiple reasons, to see whether those trend lines persist, especially as society sort of had a fundamental change. So I guess that's question 1. I'll let you answer that one first.
Yeah, I think that's a great question. I think we wanted to, so in our GE modeling, we used that natural progression of what we would expect for that cohort, and that was really meant to compare apples to apples. So I think there's definitely value, though, to looking at the trends for particularly those who aren't responsive to modulators and seeing how that compares. So I think that's an excellent idea for a next step.
And then the second thing is, for all of your, I saw the violin plots I love, but did you do either binning your data in terms of response or creating categorical variables to sort of say percentage of people with less than a 5% response, 5 to 10% response, et cetera, to see how many fall in each of those bins? Because I think that's even more interesting in terms of the heterogeneity, is to truly what are the percentage of people who are true non-responders in each of these variables. And do you have that data?
We don't have it yet, but that's part of our plan. We're working on defining, well, what do we consider a robust response?
Yeah.
Is it 10%? That's kind of where we're leaning right now, but we don't want to overlook the people who maybe responded by 5%, and that still may be a valuable improvement. So we're going to get more granular on that. Yes, forthcoming.
I have just a question on the exacerbation data, because I suppose over the last few years it's very hard to look at longitudinal changes in exacerbations because of the COVID pandemic and all the changes that took place. You talked about how you adjusted, and you kind of went from a very, very impressive rate to a little bit less impressive rate. And we know 30% of exacerbations pre-COVID were virus-related. So I'm just wondering, is that an overly conservative approach to the impact of ETI, or where do you think it lies? Or
I think that's a really good question. I'm not sure, but I think that regardless, there certainly is still an improvement, even if we kind of are overly cautious with our estimates. So I think that's useful data, nonetheless. And it's just so hard to tease apart, right? ETI was approved 3 months before the pandemic started, so that makes all of this analysis so complicated. And I don't know if my biostatistical colleagues have anything to add on that particular question, because that's really shout out to them for their work on that.
So I think you're right in that we only adjusted for calendar periods, so slicing time based on what we saw in some of the flu, like the Seattle flu study, which does really nice granular tracking of respiratory infections that coincide with the pandemic time period. And so it does not account for other causes of exacerbations. So yeah, I think it is a conservative approach, but I think we tend to err on the more conservative side to kind of really recognize the real world nature of the data.
Thanks, Liz.
Thanks. This is phenomenal data. I'm very impressed. I have a question about the people who had a obese level BMI over 30 and the graph where you show the change in slope for those who weren't on ETI was actually exceeding that of people on ETI. Does that mean that the people not on ETI are actually have like a numerically higher BMI level than people in this cohort who weren't on ETI? Yeah, that's what it looks like.
And the dashed line really is like what we predict the natural progression to be among this cohort.
Okay.
It's basically saying we would expect, had they not started ETI, that their BMI would continue to increase. I think this is fascinating, and I'm not sure what we're seeing here. One theory I have is maybe the pro-inflammatory state that people were in once they started ETI, that's improved, and could that have been contributing to derangements in their metabolic state and weight gain? Alternatively, maybe there's not actually an organic explanation, and maybe it's just that we are pushing less the high-calorie, high-fat diet among people who have an elevated BMI, and is that potentially the explanation? I'm not sure, but I think I would love to see someone explore this further.
Thank you.
I have one question if there's time. I'm curious, I kind of want to pick your brain, Georgine. Like, do you have a hypothesis for what variables or whether they're like demographic or clinical that might predict those that respond really well to ETI in terms of like FEV1?
Yeah, I'm very curious about that too. I'm excited to see what we find. I wonder if some of it will end up having to do with like microstatus. Is it people who are colonized with Pseudomonas who don't respond quite as robustly? I think it's hard to tell at this time. So I want to wait and see the data.
Great, thank you. Well, thank you so much, Georgine.
So I'd like to introduce our next speaker, who's Angela Metcalf from the University of Colorado, and she's going to be talking on the utility of sweat sodium to chloride ratio for the diagnosis of FTR-RD and CRMS.
Hi, everyone. My name is Angela Metcalf. I'm a second-year pediatric pulmonary fellow at the University of Colorado, and I'm excited to tell you about our study that looks at the utility of sweat sodium to chloride ratio in cystic fibrosis diagnostic dilemmas. My only disclosure is a first and second-year clinical fellowship award from the Cystic Fibrosis Foundation. My objectives for this talk are to discuss the importance of sweat testing in cystic fibrosis, to understand the potential outcomes of an intermediate sweat test, to describe our study and how it intends to address gaps in CF diagnostics, and to evaluate current data and future directions. I want to review the basics of sweat electrolytes in cystic fibrosis. As we know, we have this sweat gland that secretes sweat onto the skin surface. Within the mucosal surface of the sweat glands, sweat ducts are CFTR protein transporters, and they move the chloride ions from the ductal lumen of the sweat duct. They reabsorb that actively back into the interstitium. That creates a negative charge in the interstitium that the sodium moves passively down through an epithelial sodium channel. So chloride is reabsorbed into the body, and sodium follows suit. In a patient with cystic fibrosis where the CFTR protein is non-functional, that sweat chloride is not being actively reabsorbed into the interstitium, and so that sodium does not have that negative gradient to follow. And so when you have an elevated sweat chloride in cystic fibrosis, you also often typically have an elevated sweat sodium as well. Sweat chloride testing by quantitative ionophoresis remains the diagnostic gold standard for cystic fibrosis. A sweat chloride level of greater than 60 can indicate a diagnosis of CF, while a sweat chloride from 30 to 59 is an intermediate value where there's a really unclear diagnosis. A sweat chloride value of less than 30 typically makes cystic fibrosis unlikely. There are several causes of intermediate sweat tests, these sweat tests that range from 30 to 59. You can have this with cystic fibrosis that could be intermediate on one value and then could change on a subsequent test. You can have this in people who are CF carriers or people who don't have any CFTR mutations at all. You can also have this in CRMS, CF SPID, which I'll get into here in a minute, or with CFTR-RD. Some background on CRMS and CF SPID. This stands for Cystic Fibrosis Transmembrane Conductance Regulator, or CFTR-related metabolic syndrome. In Europe, it's referred to as CF screen positive inconclusive diagnosis, or CF SPID. This is defined by an inconclusive CF diagnosis following a positive newborn screen. These patients have an elevated IRT, but an intermediate sweat and less than 2 disease-causing CFTR variants. These patients typically have no clinical signs of cystic fibrosis, but they need to be followed by a CF provider to monitor for symptoms of CF. They need close follow-up and repeat sweat testing and CFTR sequencing in the first few months of life. Then they're typically followed by CF providers annually until ages 6 to 7. CFTR-RD refers to cystic fibrosis transmembrane conductance regulator, or CFTR-related disorders. It's really defined as a clinical entity that's associated with CFTR dysfunction, but that does not fulfill diagnostic criteria for CF. These patients have symptoms, but their sweat test is less than 60, and they have less than 2 disease-causing CFTR variants. Some examples here are congenital bilateral absence of the vas deferens, or CBAVD, chronic pancreatitis, or bronchiectasis. These patients should be followed closely by their PCP with consultation of a CF provider to monitor for symptoms of CF. I want to discuss sweat sodium to chloride ratios. There have been small studies that show that the ratio of sweat sodium to sweat chloride is significantly different between people with CF and people who do not have CF, and suggested cutoffs to distinguish these two are anywhere from 1.0 to 1.2. This ratio may be more helpful in diagnosing patients with intermediate sweat chloride values. Labs performing sweat testing are not required to measure sweat sodium, and some labs are moving away from this, even though it can have some helpful clinical information. So we have some knowledge gaps to address. First of all, what are sweat sodium to chloride ratios in patients with CFTR-RD and CRMS-CF SPID? Are they different from CF and non-CF patients? And can using sweat sodium to chloride ratio add diagnostic value? Our study aims to determine if sodium to chloride ratio in sweat can distinguish between CF, CRMS and CF SPID, and CFTR-RD, and patients without these diagnoses, which I'll refer to here as non-CF. Our hypothesis is that sodium to chloride ratio will be different between CF, CRMS, CF SPID, and CFTR-RD and non-CF, and will have added diagnostic value for patients with unclear diagnosis. Our methods for this study: we have a retrospective study at the Children's Hospital of Colorado and the University of Colorado and National Jewish Health. And we included sweat tests performed between January 1982 to July 2020 in patients greater than 2 days of age and less than 50 years old. We excluded non-physiologic sweat test values, including a sweat sodium to chloride ratio of greater than 2. We also excluded sweat tests with insufficient volume or sweat tests that were obtained while subjects were on CFTR modulators. We also excluded patients without demographic information, which we really used as a marker of incomplete records. We collected data on sweat chloride, sweat sodium, the date of testing, the method of testing, whether Macrodoct or Gibson-Cook, clinical diagnosis, and CFTR genotype. For subjects with multiple sweat tests, we used their first test. We manually confirmed clinical diagnosis and CFTR genetics for all subjects with intermediate sweat chlorides via medical record review. And we also confirmed unexpected results, for example, a sweat chloride less than 60 in someone with a diagnosis of CF. This is our analytic cohort. We had 7,000 sweat tests performed in the study window from 6,475 unique participants. We did limit a significant number of those because of limited demographic information. So our final analytic cohort was 2,833 unique sweat tests. Our study population of these 2,833 patients, 700 had CF. The median age at testing was 1.4 months. We had 34 patients with CFTR-RD or CRMS-CF SPID. The median age at testing there was 1.9 years, so a little older with a wider interquartile range. And then we had 2,099 patients without CF, CFTR-RD, or CRMS and CF SPID, which we'll refer to as non-CF. The median age at testing was a little older there as well, with a median of 2 years. Here are our results. Unsurprisingly, median sweat chloride is significantly different between these three groups, being around a median of 100 in patients with cystic fibrosis, 36.75, which is an intermediate sweat value in patients with CFTR-RD or CRMS-CF SPID, and a normal value, median value of 13 in non-CF. We also found that median sweat sodium was significantly different between these three groups and was significantly higher in patients with cystic fibrosis than the other two clinical entities here. We also found that median sodium to chloride ratio was significantly different. The median sweat sodium to chloride ratio in patients with cystic fibrosis was 0.88, in CFTR-RD or CRMS-CF SPID was 1.16, and in non-CF was the highest at 1.44. We also broke down our patients with CF by a high severity CF genotype with class 1 through 3 mutations and pancreatic insufficiency versus lower severity CF genotypes from class 4 or 5 with pancreatic sufficiency. We did find a significant difference in median sweat chloride with our higher severity CF genotypes having higher sweat chloride. And there was a significant difference in median sweat sodium as well, with higher in the higher severity genotypes. However, in median sodium to chloride ratio, we did not see a significant difference, both around 0.87. So holding up the idea that sweat sodium to chloride could distinguish CF from other clinical entities, regardless of what the CF genotype is. We made ROC curves to determine the validity of sodium to chloride ratios to distinguish between these clinical entities. So I want to kind of review how we look at ROC curves. We have specificity on this axis, with the upper end of specificity being towards the center here, and then sensitivity on the y-axis with perfect sensitivity at the top of the y-axis. A random classifier would go straight down the middle with losing specificity as you gain sensitivity and vice versa. But as we have diagnostic classifiers that have better sensitivity and better specificity, the curve starts to move up towards this top left corner. So this would signify what's a good ROC curve for a diagnostic test, and this would be a great diagnostic test. We measure the ability of these diagnostic tests on an ROC curve by looking at the area under the curve. So for a good diagnostic test, your area under the curve is going to be about 0.7 to 0.8. And then for a great diagnostic test, your area under the curve is often greater than 0.9. So with that in mind, I want to look at our ROC curves for sweat sodium chloride to distinguish between CRMS-CF SPID or CFTR-RD versus CF. So you see we have a pretty good ROC curve indicating that sweat sodium to chloride can be a good diagnostic test to distinguish between these clinical entities. Our area under the curve here was 0.868 with a suggested cutoff of 1.075. Looking at our ROC curves for CRMS and CF SPID or CFTR-RD versus non-CF, we have one that is not quite as robust but still quite good, with an area under the curve of 0.759 and an ideal cutoff of 1.268. So using these models, we can kind of come up with a schematic for potentially using sweat sodium to chloride ratios to distinguish between these clinical diagnoses, where you can imagine a sweat sodium to chloride of 1.075 would help us distinguish between CF and CRMS, CF SPID, or CFTR-RD, and a sweat sodium to chloride ratio of 1.268 would help us distinguish between CRMS, CF SPID, or CFTR-RD and non-CF. So a summary of our findings, sweat chloride and sodium to chloride ratio is significantly different between CF, CFTR-RD, and CRMS, CF SPID, and non-CF. Sweat chloride is different between high and low risk CF genotypes, but sodium to chloride ratio is not. And the sweat sodium to chloride ratio may have additional utility in differentiating CFTR-RD and CRMS and CF SPID from CF and non-CF. This may be helpful early data for anticipatory guidance to families when the diagnosis is uncertain. Some implications here. CF centers should consider measuring both sweat chloride and sweat sodium. And sweat sodium may be particularly helpful in ruling out CF when sweat chloride is abnormal, but no CFTR variants are found, suggesting that an elevated sweat sodium may be driving your elevated sweat chloride in these cases. Some future directions for our research, we plan to evaluate how CFTR modulators affect sweat chloride, sweat sodium, and sodium to chloride ratio. And we also plan to analyze sweat sodium to chloride ratio correlation with estimated CFTR function by genotype. Thank you so much for listening. Thanks to Dr. Martiniano and Dr. Zmanek, who have served as great mentors for me on this project. Tim Viggers, who has helped us with our statistics, and Eleanor Hanley, who has been a great resource as well. Thank you to Dr. Nick, who helped us bring in the data from National Jewish and has been incredibly helpful, and Katie Posch, who has helped us significantly from National Jewish as well. And I'll take any questions.
Thank you. That was a very clear presentation. Excellent. Any questions anybody has? I suppose when we think about CF SPID or CF metabolic syndrome, the big question is who of those are going to become somebody who has CF or doesn't have CF? Mm-hmm. Where do you see this ratio fitting in that sort of algorithm? Because I think when we get these borderline sweat tests and we diagnose CF-related these syndromes, we either go down the route of NPD or intestinal current measurements, those sort of different things. This sounds like something that could be maybe earlier on in the algorithm. So where would you see it? How do you see that working?
Yeah, I think it can be especially helpful early on when you only have one sweat test, you haven't yet had an opportunity to repeat it, or even if your CFTR genotype is pending and families are asking, what does this mean? Where you can, if you have that sweat sodium data, you can look without necessarily more invasive testing or having to wait until you're able to do additional testing.
A question, yeah?
You may have sort of already answered this question, but I was trying to piece together, do you think that this performs better than sweat chloride? Like, I don't know that you had an ROC curve for the sweat chloride. Do you think it performs better than sweat chloride, or do you more see it as like another thing you can look at when you're uncertain?
Yeah, so this would be something you could look at in addition to sweat chloride. We made a sweat chloride ROC curve at one point and then realized that it had perfect specificity and sensitivity because that's what we use to diagnose CF. Right. So we were like, oh, right. So this would just be additional information, especially in intermediate sweat chloride. Yeah.
Does the ROC curve for sweat chloride, it wouldn't have perfect sensitivity and specificity for like what the eventual diagnosis is though, right? Like if you kind of look into the future of people who had an intermediate sweat, what ends up happening to them, that might be a good ROC curve to make.
I should say, yeah, near perfect. There are certainly a few cases that, start as one diagnosis and can transition to another.
When we look at sweat...
We were also looking at the first sweat test too, so...
When we look at sweat tests, it's almost a continuum where you see the classical CF, the milder forms of CF, and then it goes down as you get into those later other diagnoses. I was struck by the fact that there wasn't a difference between the milder mutations and the severe mutations. Any ideas why that would be?
Yeah, I think it's interesting. I think that... part of it may just be that we have our sweat chloride that's elevated and the sweat sodium is kind of proportionally shifting to the same degree in cystic fibrosis. And so you just have this proportionally higher, both sweat chloride and sweat sodium following along that gradient in your more severe CF genotypes.
Thank you. All right, our next speaker is Dr. Mordecai Polak.
So hi, my name is Mordecai Polak. I come from Schneider's Hospital in Israel. Happy to be with you here today. So what I'm going to present today is data from the European Cystic Fibrosis Registry. And we're going to discuss association of change in respiratory infection after elexacaftor, tezacaftor, ivacaftor, which we'll refer to as ETI, therapy on clinical outcomes. So just for the background, and I don't think we have to talk much since we also actually saw beautiful data just not long ago of real time from the American Registry about how ETI is improving the quality of life and prognosis of people with cystic fibrosis. That better? And we did show in the European conference not long ago that ETI reduces detection rates of airway pathogens from lungs of people with cystic fibrosis. But the clinical impact of this reduction is not clear yet. This is what we presented in Glasgow just a few months ago. What we did is we used the European registry and we compared. So first of all, we identified people with CF that initiated ETI between 2019 and 2021. And we looked what happened 1 year before with 1 year after. And as a comparator group, we used the same patients, just looking at what happened between 3 years prior to the initiation and 1 year prior to the initiation. And we compared those two groups. And for some patients that started ETI relatively early, we also had data to show for 2 years after the initiation. And what we showed is in various CF-related pathogens, there was a significant reduction in the detection of these pathogens. And if we focus here on Pseudomonas, we can see this is 3 years prior to ETI and 1 year prior to ETI, and then 1 year post, you can see a significant reduction in the detection rates of Pseudomonas. And this was seen also in other pathogens, as you can see over here. And in about half of the cohort over there, we were able to follow for the second year also. And as you can see here, so again, we're looking at Pseudomonas. This is 1 year prior to ETI. This is 1 year post and 2 year post. The reduction in Pseudomonas was sustained for 2 years after initiation of ETI. So the aim of this project was to assess the clinical impact of the reduced colonization of Pseudomonas and some other common CF pathogens following ETI initiation. So using the European registry, we identified people with CF that initiated ETI between 2019 and 2021. And again, we're looking at the 1 year before compared to 1 year after ETI initiation. And then we're identifying, in this case, Pseudomonas, people that were with Pseudomonas in the year before, and looking if they're clearing or becoming not chronically infected with the Pseudomonas 1 year after, as compared to those that continued to be chronically infected. So just for definitions, what is considered being chronically infected with Pseudomonas according to the European registry? So you need to have 50% of respiratory samples in the last year to be positive, and you need to have at least 4 samples, or significantly raised bacteria-specific antibodies. And the last one is quite important. If you as a clinician don't think that there is a reason that this status has been changed, then you can continue to report him as chronically infected, even if there weren't 4 sputum collections in that year. And the method, so we used a multivariable model, adjusting for some variables, including age, sex, genotype, FEV1 predicted, and the use of CFTR modulators prior to ETI. And as a socioeconomical status, we used a global national income, a global net income, sorry. And these are our results. So we identified just over 15,000 people with CF that were initiated ETI. And as you can see, most initiated the therapy between 2020 and 2021, with just a few in 2019. So the mean age was around 27 years, 53% were male, pretty much half-half or just a bit more that were homozygous to delta F or heterozygous, and then a minority that did not carry the delta F mutation. And the mean predicted FEV1 was 74%. So we have 15,000, as I said, that initiated ETI, and in the year before initiation, we identified 6,000 that were chronically infected with Pseudomonas aeruginosa. And if we're focusing on that group, we had, of those, 61% that were continued to be chronically infected in the year post-ETI, as opposed to 39% that were not chronically infected in the year post-ETI. So here I'm showing this will be the only slide that is showing you crude data without any modeling. And what we see here, every small circle here represents a person with CF, and the red ones are those that became not chronic in the year after ETI, and the black ones are the ones that can continue to be chronically infected with Pseudomonas. And as you can see, in the x-axis, we're looking at FEV1 pre-ETI, and then the delta, how much did they change once they started using ETI. And so you can see that there's improvement just under 10%, and that this is not very different between those that were continued to be chronically infected or not with Pseudomonas. And this is with a statistic model. So again, we're looking here at FEV1 prior to ETI and the delta. And in the red, we're looking at those that became not chronic, and in the black, we're looking at those that remained chronic. And you can see, something interesting to see is that there's some kind of like a hump over here that shows you that if you started out with around 60% of FEV1, then you are going to be the one that will improve most on ETI therapy, and this goes lower as you go to the sides. And that makes sense, because if you have a very high FEV1 prior to ETI initiation, you probably don't have room for much of an improvement. And if you're doing worse, then your lungs are probably already sick in a way that you'll improve less than those that are here in the middle. But if we go back to our aim of this study, we did not see a statistically significant difference between those that became not chronically infected with Pseudomonas and those that remained in terms of the FEV1 change. Here we're looking at the BMI, again, according to the Pseudomonas status. So we're looking in those that are above 18, we're looking at BMI, and those that are under 18, we're looking at Z-scores. And in both cases, we did not identify a statistically significant change in those that became not chronic or remained chronically infected with Pseudomonas. Just again, we're looking at the BMI prior to ETI, and then the delta, how much did you change? Because there is a change once you start ETI, but again, there's not a difference in the change between the groups of those that became not chronic or remained chronic. Here we're looking at the change in IV antibiotic days per Pseudomonas status. So again, in the x-axis, we're looking at days on IV antibiotics before ETI, and then the delta, how much did that change? And this is on the negative, because you have less days of IV antibiotics once you use ETI. And what we found here is you have marginally larger increase. So you have less days, I'll soon show you the results, less days of IV antibiotics if you stopped being chronically infected with Pseudomonas, and this was actually statistically significant. But here it is important to dive into the numbers, and because especially when you have big data, not always what is statistically significant has also a clinical meaning. So if we look here, for instance, we take around the 2-week point, we're looking at around 14 days of IV antibiotics prior to ETI. So those that remained chronic will have a reduction of 11.9 relative to those that had 12.2 days if they became not chronically infected with Pseudomonas. So it's like a 0.3 day difference. So this is statistically significant, but again, I'll leave the question open if this is also clinically meaningful. In terms of any hospital days for any reason, so here we did find a larger reduction in hospital days for those that stopped being chronically infected with Pseudomonas. Again, let's look at the 14-day point. So those that remained chronic went down to 4.6 days, and those that stopped being chronic had only 3.2 days expected days of hospital admission, and this was statistically significant. Let's look just a little bit also in MSSA, methicillin-sensitive Staph aureus status. So again, this is our cohort. We had 5,737 people with chronic MSSA prior to ETI, And of those, 53% remained chronic the year after ETI, and 47% were not chronic. And what we see here, again, we're looking at FEV1 prior to ETI and the delta. And here you can see we got some significant results that actually surprised us. So what we see here is that those that became not chronically infected with MSSA actually were doing a bit worse compared to those, or I wouldn't say a bit worse, but improved less compared to those that remained MSSA chronic. And so if we look again at those that had 60% around prior to ETI initiation, so those that remained chronic had an increase of 15.1 in FEV1, and those that stopped being chronically infected had only 13.5% increase. The main results: a reduction in Pseudomonas is associated with marginally less IV antibiotic days and less hospital days, but not with a change in FEV1 or BMI. And then we saw that a reduction in MSSA was associated with a bit less of an FEV1 improvement. So as any other study, this study has strengths and limitations. So this is a real-life study, registry data, and it's a very large and diverse cohort. We had included here 30 countries from around Europe, and we adjusted for quite a lot of factors. The limitations, once again, it's registry data, and we're limiting what we can capture from there. These are COVID-19 pandemic years, as was mentioned in previous talks here. Another thing to discuss is we know that people using ETI are less productive. They combined with the COVID also probably have less visits, so probably less sputum is collected. And so that might influence the change in what we call chronic or not chronic for Pseudomonas and other. And then there's some therapies that we could not adjust for instance, inhaled antibiotics, and that's very important, especially for Pseudomonas. So I think some points to discuss are, first of all, what leads to this reduction of detection that we showed here and in Europe? Is this improved just because of the improved CFTR function because of the medication, or is there just less sputum, difficulty to expectorate, less clinic visits? So that's one question. And then what is the clinical impact of this reduced detection? We did not find a difference in FEV1. We did find a bit less IV antibiotic days and less hospital days. So, I mean, and we all know that Pseudomonas is something that we aim to eradicate, and we know that people that have Pseudomonas have quicker deterioration in FEV1. So do people that use ETI, we can call it like ETI lungs, do they react differently to this Pseudomonas? I think it's early to know that, and it's something that we should continue monitoring. What is this? Why do we see a better improvement for those that are using, that are remaining, that stopped being, why are those that are remaining chronically infected with MSSA doing a bit better than those that not? Perhaps they're allowing for other pathogens to have a more important role in the lungs at that time. That's something that we still have to check. So to conclude, ETI changes airway infection detection rates, but FEV1 improved similarly. The impact of chronic airway colonization or infection might be different under ETI treatment and might change over the years. And so I think really what we have to do at this point is to continue sampling our patients and insisting on good sampling until we know we have a better picture of what the meaning of these detection that we saw is. So I would like to thank the statisticians that helped us with this study, which is mostly Simon and Annalisa from the European Registry, Professor Dara Price and Professor Eitan Kerem that are sitting with us here. And unfortunately, Dr. Meir Mezahav could not attend. And of course, to the people of CF and their families that were included in the registry. Thank you.
We have one question in the audience.
Yeah, so great talk. Just for my own, just pure morbid curiosity, did you stratify the data by country? In other words, are these effects, because Europe is like a big place, right? So each country has its own healthcare delivery, its own healthcare system. Is it even fair to lump all these different countries together as a patient population, or should it be stratified?
So we didn't stratify for each country, but we did for GNI. we can look into that. I don't expect to see a big difference, but I think GNI would be the right thing to do here, but we can definitely look at that also.
Okay.
I have a question. You mentioned the leads criteria which we use in the registry to determine Pseudomonas positivity, and looking for 4 sputum samples in a year of CF patients on ETI is a big ask. And then the alternative is if sort of physicians gestalt, you say they're about their feeling about it. Do you know, have those trends changed over time with the registries in terms of how we're recognizing whether somebody's positive or negative for Pseudomonas? Should we be looking at that in a different way?
So for now, the registry did not change the way to determine chronically infected, but I think, first of all, moving from 2021 and on, so the registry doesn't look only about you're supposed to fill in the registry not only are you chronically infected or not chronically infected, but did you have any sputum culture positive that will also be registered. So that's going from 2021 and on. What is still not captured, and I think decision makers should think about that, is to also determine how many cultures were taken every year for the patients, because that is significant data that unfortunately I don't have at this point.
Great, thank you.
Great. Our last speaker today is Dr. Joel Mintz from University of Miami.
Hello, everyone. My name is Joel Mintz. I'm a PGY3 at the University of Miami Jackson Memorial Hospital. And thank you very much for coming to our talk, Increasing Prevalence of Cardiac Discharges and Cardiovascular Comorbidities Among CF Hospitalizations from 2012 to 2020. This is our research team, and I have no disclosures. So due to advancements in the treatment of cystic fibrosis over the past 3 decades, a patient who is born with CF today has an average life expectancy extending into the 6th decade or more of life. However, with increasing life expectancy comes increasing number of years at risk for cardiovascular disease. And it's well known for other chronic respiratory diseases like COPD that with decreasing lung function yields an increased incidence of other cardiac comorbidities. The incidence of major adverse cardiac events was estimated at 1.3 and 0.3%. Using 2 different database methods, or 2 different, one of this UK CF registry and as another, one of the Trinex database studies, which is similar to our own. And overall, there's a greater risk of cardiovascular disease in CF patients than the general population. However, how patients with CF develop cardiovascular disease and their subsequent long-term outcomes is unknown. So what are the potential mechanisms of cardiovascular disease and cystic fibrosis? The first of which being atherosclerosis. Patients with CF have abnormal parameters of endothelial cell dysfunction, which over time yields increased thickness and stiffness of blood vessels, contributing to cardiovascular disease. Chronic inflammation causes blood vessel damage, leading to lipid deposition and smooth muscle proliferation, also contributing to this. Chronic hypoxemia contributes to chronic inflammation, but also induces small molecule signaling within the cardiovascular system as a whole, further contributing to chronic inflammation or further contributing to cardiovascular disease. The rates of obesity in patients with CF is anywhere estimated between 1/4 to 1/3 of the patient population. And overall, these people are more likely to have risk factors such as hypertension, which also contribute to cardiovascular disease. Sleep disordered breathing, which is very common in patients with CF, worsens nighttime hypoxemia and chronic inflammation, further contributing to cardiovascular disease. And one of the unknowns is how cardiovascular CFTR dysfunction within the cardiovascular system itself contributes or compounds upon these risks. And diabetes, which is extremely common within the CF population, is a well-known established risk factor for cardiovascular disease. And finally, issues involved in transplantation and chronic immunosuppression can also sort of compound upon these risks. What's not listed here is how chronic exposure over the lifetime to antibiotics further changes the gut microbiome, which then further contributes to cardiovascular disease. All the area of this research within both adults who do not have CF and within the CF population is unknown. So we asked a few research questions in terms of the context of cardiovascular diseases, the first of which is how has the incidence of cardiovascular disease changed over time for patients who are hospitalized with CF? And we suspected that incidence overall, given these risk factors and the increasing life expectancy, was increased. Furthermore, then we asked how does cardiovascular disease impact outcomes of patients who are hospitalized with CF? And we suspect that overall these outcomes are worse. So we designed a retrospective cohort study using the national inpatient sample from 2012 to 2020 of adults age greater than or equal to 18 years old who had the discharge diagnosis of cystic fibrosis, which was not restricted by discharge diagnosis position. We excluded patients who were admitted electively or who had a length of stay less than or equal to 1, essentially observation or met observation criteria. Our outcomes was the overall cardiovascular disease incidence assessed as by ICD code, as well as cardiac DRGs. We also looked at mortality, length of stay, the non-routine discharge rate amongst survivors of the hospitalization, the intubation rate, and the total cost in 2021 dollars. So what exactly is a diagnosis-related group? Essentially, it's a way or a means that Medicare has made to identify patients who have a similar process of care and a predictable range of services. I like to say this as these patients were admitted for primary cardiac reasons. Listed on the slide is essentially the DRGs related to acute myocardial infarction. And you can see the 6 DRGs that outline this, whether or not they were discharged alive, yes or no, whether this was considered a major clinical complication or comorbidity or a clinical complication or comorbidity. We use cardiac DRGs 215 through 330, aka the major diagnosis category 5 for Medicare data, which includes both not only medical related cardiac DRGs, but also cardiac surgery related ICDs, for example, hospitalizations that were related to implantation of an AICD device or pacemaker. We designed our study in 2 phases, the first of which being a trend analysis, where we assessed the trends of each cardiovascular discharge diagnosis and DRG over the interval period using Cockridge-Armitage test to test for trend across the discharge quarter and years. And then due to trends that we observed, including 2020, we then subsequently excluded the COVID year due to trends that we observed. Secondly, we then performed a clinical outcomes analysis to determine the association between each individual cardiac discharge diagnosis and the DRGs with the individual outcome. We used a hierarchical multivariable regression analysis, which was stratified by NIS-defined strata and year. And then we used negative binomial and logistic regressions to analyze continuous and categorical variables respectively. And we controlled for our model by including relevant socioeconomic, hospital, and clinical characteristics to the best of our ability using ICD codes instead of actual clinical data provided per these each hospitalization. So in total, contained over these years was about 63 million inpatient records. And after excluding patients who were not considered adults, admitted electively, or who met observation criteria, we were left with about 28,000 CF hospitalizations across 3,500 hospitalizations in the United States. Using weighted sampling provided by the NIS, so this revealed a total cohort size of about 141,000. CF hospitalizations across these years. The average age was about 32. Most were whites who were discharged between the years 2012 to 2019. And most came from urban teaching hospitals, which were non-for-profit, located primarily in the South, although we did have a good representation across the United States. The overall discharge, like the other clinical comorbidities, included hypertension and diabetes at a rate of about 16%. The most common comorbidity was that of chronic pulmonary disease at 50.1%, and about 27% had codes for Pseudomonas colonization and 31% for exocrine pancreatic insufficiency. So here we see the overall incidence of cardiovascular discharge diagnoses per year, as a grouped per year. The most common cardiovascular disease was the incidence of NEA arrhythmia, about a little over 8%, and the overall cardiac DRG was about 2%. Next, the second most common was hospitalizations, which also had discharge diagnoses for congestive heart failure and pulmonary hypertension, a little less than 3% itself, followed by AFib, coronary artery disease, which was less than 2%. The overall mortality rate of our study was about 2%. Amongst survivors, 25% about 25% or so had non-routine discharges to facilities, and about 4% were intubated. Our median length of stay was about 7 days, and the hospitalization cost about $17,000, and adjusted for 2021 dollars. Here we see the cardiovascular disease incidence over time throughout our study period, where the yearly incidence is on the y-axis. And we can see that over the interval period, that overall the cardiovascular discharge diagnoses across every single cardiovascular discharge and DRG increased. And we can see that in 2020, there's a noticeable jump across all of these essentially cardiovascular diseases, which led us to think that essentially that would these trends be repeated if this nonlinearity was removed, and it subsequently was for every cardiovascular discharge besides that of pulmonary hypertension, which approached significance but did not reach it. So the next question that we asked is, what are the specific clinical outcomes of CF hospitalizations with cardiovascular disease? In the left-hand column, we see each individual either cardiovascular DRG or their individual cardiovascular disease, as well as the adjusted odds ratio and adjusted incidence rate ratio in the columns that precede it. First and foremost is that patients who were admitted for a primary cardiac cause or had cardiac DRGs were not really associated with adverse outcomes, and there was even some trend when compared to the average CF hospitalization that there may have been some improvement in outcome. However, for patients who had MI or heart failure or stroke and pulmonary hypertension, these were associated overall with worse outcomes for CF hospitalizations. And then for coronary artery disease and AFib, these, coronary artery disease may have had some benefit when compared to the average CF hospitalization, and AFib generally had no association that we observed. So what does this all mean? Essentially, this means that there's an increasing number of CF hospitalizations for primary cardiac reasons. And overall, CF hospitalizations who had discharge diagnoses of cardiovascular disease also increased as well. It appears to be that cardiovascular disease are probably associated with worse outcomes for CF hospitalizations, although this is likely not within the context of a primary admission for a cardiovascular cause. In such that a patient who is admitted for respiratory failure, where it's subsequently complicated by pulmonary hypertension or CHF, tends to do worse than maybe a CF patient who was admitted for MI alone. Importantly, there are many limitations to this analysis, and the first of which is that using discharge diagnosis codes overall have a low sensitivity and specificity, potentially leading to outcome misclassification. We saw that previous presenters have reported Pseudomonas colonization rates ranging into the 60%, where ours is much lower, into the less than 20%. Using our weighted sampling method can potentially lead to oversampling of CF hospitalizations, and important to note that we're looking at specific hospital admissions, not individual patients. So a patient who is constantly readmitted to the same hospital or even a different hospital is identified as each hospitalization is considered separate using this analysis. It's important to note that over the study period, the number of potential discharge diagnoses within the actual NIS itself increased. For example, in 2020, there was 20 other possible sort of associated discharge diagnoses, whereas in 2012, there was 20. And 2020, there was up to even 40 potential discharge diagnoses that could be included. And that, of course, throughout the study period, but not only did this shift from ICD-9 to ICD-10, but ICD-10 itself also got constantly refined and updated once, I believe, in 2017, and then again in 2019 as well, allowing for more coding, which we weren't necessarily able to classify throughout the study. Furthermore, we're unable to account for CF-specific phenotypes, which may influence outcomes. For example, CF-related diabetes or CF-related liver disease. Sometimes these are either miscoded as just regular diabetes or regular sort of liver disease, or they're grouped together, essentially cystic fibrosis with other specified or unspecified complications. And then finally, this doesn't include other parameters which you may want to know when evaluating disease severity, for example, FEV1 function or essentially other clinical parameters which may influence outcomes. However, we do think that despite these limitations, this is a call for improved recognition and screening of cardiovascular disease amongst the CF patients in general, and importantly that these may need different screening tests than the general population given the special risk factors that we mentioned earlier. One common method that we do in clinic is using of the ACVSD risk calculator to essentially see who would benefit from statin therapy. However, the average age of our cohort, despite the overall incidence of cardiovascular disease being somewhere between 2 to 4% for each individual cardiovascular disease, these patients wouldn't even qualify or couldn't even be calculated using that because of their overall age. And then future studies are needed to determine the impact of aggressive cardiovascular risk factor modification on patient outcomes, for example, treatment with statins or newer agents, even in patients that cannot tolerate a statin based on other complications. And then we need additional research on potential mechanisms which drive cardiovascular disease and impact of disease-specific treatment. It's important to note that our study may be, that of course will be affected by the approval of recent ETIs and other CFTR modulators, which may or may not be sort of, we probably are not sort of capturing those patients within the context of our study. So with that being said, here are some references. Thank you for the people that made those stencils online. You are the true heroes of this presentation, of course, with patients with CF and their families as well. So with that being said, I'll take any questions and answers, and thank you so much for staying. I know it's almost lunchtime, which is the true session that everyone wants to get to, so thanks.
I might start with one, actually. I think it's been very interesting. There's been a lot of discussion about cardiovascular risk factors in CF patients. One of the things, we use a lot of Zithromax, as you know, and in older people with COPD and so on, if they've got cardiovascular disease, we tend not to use it because we're worried about arrhythmias. You may end up quite a high level of arrhythmias as part of the presenting features for the cardiovascular complications of CF. What do you think? We should be more careful about using some of these drugs?
Well, I think in any, it's very specific to the individual patient. Because at the end of the day, oftentimes in CF patients, the benefits of these treatments outweigh the risks. And, you know, when a patient is sick, for example, they're sick in the hospital with chronic respiratory failure, you know, you might want to check an EKG and make sure that their QTC is within normal limits and that's not 550 or 600 before you essentially apply these medications. And that kind of goes back to how we screen patients for cardiovascular disease as well. Should patients get a routine screening EKG, either in clinic or upon admission to the hospital? I'm a personal believer in that even patients without CF should also have those screening EKGs, but certainly in this case, when you're providing therapies which have the potential serious harm, even if those harms are relatively rare in true clinical practice.
Mm-hmm. You have a question over there?
Jonathan Todd, CF Foundation, great presentation, and I really appreciate you shining a spotlight on something that I think is going to be an increasingly important topic among all chronic diseases in CF care. One question, and I really appreciate the fact that you focus on the multifactorial aspect of CF, or of cardiovascular disease in CF care. I'm curious how you, in your practice, you handle coordination of cardiovascular care with your CF practice and your cardiovascular care. How that coordination is happening? Are you working with specific cardiovascular care? Are you initiating those sort of aspects of care in your CF care? I'm really interested in kind of the handoff aspect of this topic.
Yeah, so just to make sure that we understand my experience, as a third-year resident, my experience in our CF clinic, which is amazing, is very limited and essentially ranges on the scale of days and not weeks. So to answer your question is that, of course, more experience is needed in order to understand how we can sort of optimize these risk factors from a clinical standpoint. I think one of the things that our sort of team is looking at is essentially using new screening methods to essentially screen patients for cardiovascular disease, for example, calcium scoring and things like that, and what is the right interval of time to apply that. But unfortunately, and hopefully in the future, maybe 5 years from now, I'll be able to answer that question with a little bit more of a personal experience, but I'm unable to do that right now, so I apologize for that.
I can answer the question.
Oh, please. Thank you.
I'm Carreto Payachi from University of Miami. So how we coordinate the care is, well, we start with educating the patients once they're on ETI. Once we get lipids that are elevated, there is a significant change, we refer to our cardiologist. We are lucky that we have a general cardiologist who is also the husband of our other CF provider, so it's easy to get those patients in clinic, and he gets more education, and he really understands everything that goes along with CF and the problem with starting statins in patients on ETI and because of the liver toxicity. I don't think we have the perfect model, but that's kind of how we do it and how we're starting to be more aware of these cardiovascular diseases that happen in our patients.
Lutz Nehrlich, Germany. I think one question, great presentation. I think, have you taken the age categories into consideration? Because the CF population is much younger than the other population, the non-CF hospitalized one. And I think it's always worth to see it in the background, I think. And I missed, perhaps I missed it, the arterial hypertension and obesity as a risk factor or as a comorbidity. Maybe I missed it. Yeah.
So to answer the second part of your question, is that obesity was actually included in the model. I'm sorry that it's not listed here. And the overall arterial hypertension rate was about 16.3%. I don't, off the top of my head, exactly recall what the incidence rate of obesity was, although it was adjusted for within our model. And as far as the second, the first part of your question is, I think one of the sort of future directions of this project in particular is developing specific subgroups for which we sort of want to essentially investigate. I think it's important that when we consider the use of these database studies is that it's important upfront to develop a plan, like an implementation plan, so that, here is our hypothesis, here's how we seek to investigate it, and not necessarily sort of deviate from that protocol, sort of more in a data purism type approach. And so since we didn't necessarily plan for that, we didn't execute that. But I do think that
especially for the arrhythmia, I think it would be interesting to see if it's a younger population, independent of aging, I think is affected, that could prevent.
And I think that, and I appreciate that, and I think that's a good area of investigation for the future.
Hi, Freddie Frost, Liverpool. Really nice presentation. We see in bronchiectasis and COPD that there's a particularly heightened risk of cardiovascular events after exacerbations. Do you get any flavour from your data about what's gone on before those cardiovascular events, either in terms of exacerbations or healthcare utilisation at all?
Yeah, so I think that's a good question and an important point. Is unfortunately these are what we're looking at is essentially individual data points at the time the patient is discharged from the hospital. And essentially it's a list of essentially ICD diagnosis codes and procedure codes, which you're uncertain about the exact specifics of what happened during that hospitalization outside of the day of the cardiac catheterization was day 3, right? But what are the circumstances that led up to, before, or afterwards is unknown. There is a similar database which also looks at readmission-based analysis, but unfortunately that data is not included here and is a separate analysis. So the answer to your question is that is one of our limitations as well.
All right, thank you, Joel.
Thank you, appreciate it.
Okay, so just 2 quick things. First, thank you for attending the workshop today. And the second is let's please give a round of applause to all the great speakers. Thank you.